just in case. We are ahead of schedule. First, I'd like to thank the organizing committee for inviting me. I think this is quite a difficult subject they chose for me. Actually, I was given the opportunity to change the title of my speech, but I didn't. Maybe I regret it. This is what I'm trying to talk about. The picture in the background is taken from my side of the water. It's called the Sound, Öresund. You see a small ferry running. On that side we have Elsinore. Elsinore is a suitable place when you're talking about death and dying, because about 500 years ago William Shakespeare placed Hamlet in the Elsinore castle. That's nice to know. The weather is dramatic. Copenhagen is somewhere down there, quite close. It's only 4 kilometers from Helsingborg to Elsinore. I'm a clinician, has always been, and worked most of my time with taking care of patients in Helsingborg, Malmö, Lund University Hospital, and now I'm back in Helsingborg. And I've been also doing some registry works for the past 15 to 20 years, regionally and nationally. So I will start with some registry perspectives. And as you might note, this will be a mixture of some facts, so many questions, and some unsystematic reflections from my part. First of all, we know this, that the global incidence of renal replacement therapy, that is active therapy, is increasing and decreasing at the same time. This happens between countries. You can, for example, look at the ESRD data. They have a chapter on the international comparisons. And we can also show it within countries, for example, in Sweden. I will show it shortly. And if you look, some of you who are interested in epidemiology of kidney diseases know these figures very well. There are huge variations in the incidence of treated end-stage renal disease. And when I show these pictures to my medical students, they always ask, how come? And as most of you know, there are a number of reasons for this, and I will of course not go into that, but you know we all know that there are huge differences. And we also know that hemodialysis is the dominant treatment globally, of course, with great variations between countries. These are figures from the latest EDTA registry report. And we also know that in many parts of the world the incidence is increasing in a problematic manner. Great burden of disease, great economical burden on the healthcare systems, of course. But there are a few countries where the incidence, and these are actually unadjusted figures, so if you adjust for the age and the comorbidities of the population, the incidence really is decreasing still more. Austria, Sweden, Scotland, Denmark, Finland, Iceland. And if you think that the curves are going up and down in an incomprehensible manner, that's because the populations are rather small, but the trends are very clear. And in Sweden, we analyzed, based on our registry data, variations by region for a 20-year period. And within Sweden, who has 21 healthcare authorities, you see in for example, Skåne, my healthcare authority, we have had an increase from the two periods, and in other parts of Sweden we have had a decrease in incidence. How come? What's going on? Are we seeing the results of successful preventive nephrology? Probably yes, we would like to believe so. But is it all of the explanation? Or is it increasing economic constraints? To speak clearly, are we dealing with rationing of renal replacement therapy for old and sick people? Even if we as nephrologists would like to think that that is not the case, and I think it is not the case in many places, but I think it can be the case, or it will be the case, if we are not very thoughtful about how we deal with this problem. And this is what we are really going to talk about. Are we becoming more aware of the limitations of renal replacement therapy and the opportunities of a good end of life with the use of renal palliative care? And I think there is mounting evidence for this, as the previous speakers has shown. And now I'd like to show you some graph, some figure from the EDTA annual report. It has been shown for the last couple of years. As nephrologists, we like to think that we make a difference. But when you look at the expected remaining years of life in various age categories, and you see what happens if you dialyze, and you see what happens if you are on a kidney transplant, you see it's not a question of life or death. It's a question that is more, it's a grey scale more than black or white, if you see what I mean. So, in a sense, it's quite clear from this figure when it comes to survival that even active care is in some respect palliative. That depends on how you view the problem. So kidney transplantation, we all know that that is good. Mortality rate is still higher than in the normal population, and quality of life is good. Sometimes it's unduly surrounded by too high expectations, is my experience as a clinician. Not all transplanted patients have that perfect quality of life that they expect. And dialysis is doing everything from almost as good as transplantation. In some cases we have good hemodialysis or good peritoneal dialysis and so on. We all know that. And in these patients, I think both groups we can, of course, measure health-related quality of life. We do it, some of us, and we can do it. And when it comes to dialysis patients, we know from several studies that they don't have a good quality of life. And as I tried to show you from the previous slide, I think we make a mistake if we say that there is a strict boundary between some modalities of dialysis and palliative renal care. Some of the earlier speakers talked about palliative PD, for example. That's what we have. It's a fact. We also have palliative hemodialysis. I will skip this slide, it's too personal. But when we started at my hospital, my head was a bit wondering what he had done. And that's because we had read this a very old paper from 1985. It was one of the first studies published in a large, in the New England Journal of Medicine already 85, and you see some of the old famous names among the authors. And that was not a very uplifting read. And since then, the literature on health-related quality of life and kidney failure has grown enormously. I did this search a couple of days ago, and I found over 4,000 papers. And when I added palliative care, I found 156 papers. So there's an expansion of the knowledge in this area. A couple of years ago, there was an update of the clinical practice guidelines for hemodialysis. And there was a clear difference between that guideline and the previous guideline about 10 years earlier. They had a much larger focus on individualized care, not so much focus on metrics, more focus on individualized care. And in one of the guidelines, I find this: 61% of the patients who had started hemodialysis regretted this decision, and more than half attributed this decision to their physician. So I went further on and looked at some of the references, and of course some of you has already referred to this comprehensive article, so I won't go into detail. It gives a global picture of supportive care, palliative care. We use different words for the same thing. And these authors and these articles has already been referred to. You can find them when you go to the PubMed. Here's another article, another author who has been already referred to from Australia, I think. That article contains some really shocking, I think, reading for a clinical nephrologist, because when we read it, we know it's true, but we don't really want to think about it so much as we should. They lifted 4 major themes. One of the themes was that we are bad at confronting mortality. We like to be active, we like to save life, we like to do good things for our patients, but we don't so explicitly talk about death as we should, perhaps. And the patients also feel that they have a lack of choice. Not many, but some of my patients ask me directly, do I have a choice? And yes, of course I have to answer, yes, you do, but, and so on. And I think patients also need to gain knowledge of what options there are and weighing the alternatives that are at hand. And another thing that struck me as very true, and I'm afraid I've been doing work in nephrology in more than 30 years now, but I think I'm afraid I recognized myself when I read this. We often talk about this too late, and sometimes we talk about it at the same time that we talk about the need of creating some form of access. Now it's about hemodialysis, but it can also be about PD access, of course. So we are not doing as good as we should, I think. And Dr. Davison from Canada, who has also been referred to, in the conclusions they said that that was what was referred to earlier. That more patients wanted to die at home, about 1/3, or in a hospice environment, and less people wanted to die in the hospital. Less than 10% of patients reported having a discussion about end-of-life care issues with their nephrologist in the past year. And that's a shocking figure, I think. We should do better than that. So the conclusion is current end-of-life clinical practices do not meet the needs of patients with advanced CKD. I think in my clinical practice I have come across three sort of typical patient scenarios. The first is when you have time. The patient is coming to you regularly in the outpatient clinic, and we have time to discuss and we have time to choose the palliative care pathway. And in those instances, of course, you can and should use the patient-related outcome measures, as several of the speakers have already shown. So that should be useful to improve the quality of care. But one problem we have is late referral. This makes this practically impossible. And James Heath yesterday showed a famous picture where a bombing plane has come down straightly into the ground, and that's what he means with a crash lander. A crash lander can also be someone who comes in with an acute kidney injury and never recovers, and those kind of patients are also can be called crash landers. And in these instances we have more difficulties in doing this kind of discussions with the patients, and it should also be quite difficult to measure quality of life with prompts of any kind. And then we have, I think, a situation that is becoming more and more common, that when you start the patient on dialysis, the patient is young and rather good health condition, and then the years go by, and then we have to, sooner or later, move to dialysis of a more palliative, symptom-relieving kind than the, from the beginning, optimal or adequate dialysis that we want to give. And I think this is becoming more and more usual. And in those cases, of course, it's possible to use patient-related outcomes. Probably we should, but I think it will, in practice, be more difficult, but can be done. When I think it's nearly possible to use patient-related outcome measures in the sense that we know it is when you stop dialysis, because we haven't got the time. We have to look at the quality of dying with some other kind of instruments. That man asked that question in quite another setting a few months ago. What have we done in Sweden? We have in the Swedish Renal Registry implemented use of the RAND 36, which is a generic version of the SF 36, which is one of the patient-related outcome measures that are generic and commonly known. And we have started to use it in our CKD population, and we are doing it regardless of what treatment choices the patients have done. And we plan to use it in the dialysis population. Probably we will start this autumn. So it's a work in progress, but it's low coverage and it will take time. But results will come sooner or later. And as a registry person, I would like you to look at this picture of Lord Kelvin, and you all know he said many things, but he was one of the people who early knew the good things about measuring things in order to be able to improve it. You've seen these citations many times. But I think we have some difficulties. We have some renal care dilemmas. I mean, if you look back at the practice of dialysis, we had the National Cooperative Dialysis Study, which was published way back in 1981, and the data was acquired in the last part of the 70s, and we are still in the sort of never-ending debate of how to best quantify and prescribe dialysis. Everyone knows that the KT over V or or developments of KT/V is not a perfect measure, but no one has come up with any measure that is as easy to use and can be followed in that manner. We have millions of dialysis patients and even more millions of CKD patients that this affects their survival and this affects their quality of life. And we have a need of shared decision making, and I think that's in a very various cultural settings that is very different what you mean by that. But in our part of the world, I think we are relatively on the same level. And we need it. We need to measure patient-reported outcomes and experiences when it makes a difference, and I probably think it does makes a difference. But I'm not sure, if you came to listen to my talk, if you wanted to do how to do it, I don't know how to do it. What is the best instrument? There are several instruments. This is from this article by known names in these fields. Generic prompts, yes, they have their pros, but they also have their cons. They are not too specific and sensitive in renal care. And there are variations that are more sensitive and more directed, but I'm not really sure how to do it. I think we need more science and more papers and more studies and more research on this before we know. And until then, I think one of the most important things is to talk to our patients in due time, in a timely manner, and get the patients to our outpatient clinics. So this is a picture of one of my granddaughters standing in Helsingborg looking in the direction of Denmark for the future of high-quality renal care. Thank you.
Thank you. Thank you. Is there any question at this point of time?
Yes. Thank you, Dr. Prutz, for your excellent presentation, and I can assure you that since yesterday, President Trump is not allowed to block you anymore on Twitter, as you may know if you read the news. It's good news. But I have one question about your presentation, because in my experience, there is often let's say